Good afternoon, everybody. Thank you so much for joining us for today's Leaders Initiative seminar. My name is Stephanie, and I will be monitoring things here on the back end. If you have questions, you can put them in the chat or feel free to unmute yourself when we get to the Q&A part. Our next Leaders Initiative series will be on March 17th. Dr. Kyle Conway will present relationships between renal and cerebral vasculature, implications for the classification of cerebral vascular lesions. Also pay attention, I will be sending a Qualtrics evaluation for this event towards the end. I'll just pop it in the chat. You can fill it out there, and I'll also send everything in a follow-up email as well. And with that, I'll turn things over to Courtney to do the introductions.
Thanks, Stephanie, and thanks so much, everyone, for joining us today. We're thrilled to welcome Dr. Florence Johnson as our speaker for this month. Dr. Johnson is a second-year postdoctoral scholar with the National Clinician Scholars at the Institute for Healthcare Policy and Innovation, and a research fellow at the School of Nursing at the University of Michigan. Dr. Johnson's research explores community support services for Black caregivers of family members living with Alzheimer's disease and related dementias. She is especially interested in disparities in the use of these services and the impact of support services on caregiver mental health. So with that, I'll hand it over to Dr. Johnson.
Thank you, Courtney and Stephanie, and I appreciate the opportunity to present my work. This is work that I completed during my doctoral program. How did this all begin for me? I'm very passionate about caregivers and caregivers' mental health. Across the screen, you see people who have impacted my life and my decision to study caregivers. Aunt Bert was the first person that I knew who had cognitive impairment. And back in the 80s, we did not have that term, cognitive impairment or dementia. People who lived with cognitive impairment were labeled as being senile. So Aunt Bert, who was unmarried and had no children, was diagnosed with being senile, and her brother, who was married to Johnny May, who you see in the picture, the second picture to the right of me, that's me on the left when I was younger. So Johnny May took care of Aunt Bert at home. She worked full time, and although she had 7 adult children, she was the primary caregiver for Aunt Bert. There was no home care services, there were no support. She worked her 8 hours a day, and she came home and started all over again with Aunt Bert. The next picture is Vicey. She's the one in white. She is a nurse, had been a nurse for over 40 years. That's her mom in the blue that she was taking care of. She was the primary caregiver for her mom. And she didn't realize that she was a caregiver until she attended my dissertation. You hear this all the time, people saying that that term doesn't resonate with them. And I actually have someone that I know who did not realize she was a caregiver. She didn't know where to start to look for help, even though she was in the profession of healthcare. And then the last picture is my brother, Kenneth. He lives in the Netherlands and started having some cognitive impairment. And I could tell from our phone conversations that there was something going on. So I played the caregiver from here and helped his daughter navigate their healthcare system and got him diagnosed about 3 years ago with dementia, and he now lives in a facility. So I hope you can understand why I'm so passionate about this work and making sure that we take care of our caregivers. According to the Alzheimer's Association, over 11 million Americans provide unpaid care to people living with Alzheimer's disease and related dementias, or ADRD. They provide they provide this care to 7 million people who are living with ADRD. Most of these older adults who are living with ADRD prefer to live in their homes and to stay in the community, which thereby requires them to be taken care of by family caregivers. Most caregivers are related. their friends, their spouses, but they could also just be neighbors. The fact is that they provide over 18 billion hours of care that is valued at this time nearly $346 billion. 70% of these caregivers report feeling stressed, especially when engaging in coordinating care and navigating our complex healthcare system. And according to the Alzheimer's Association, there's an estimated 2.4 million African Americans who provide care for someone who has ADRD, making them the largest group of caregivers. So what do these caregivers do, you ask? They provide the most demanding and essential care needed to care for people in the community. They perform these activities of daily living, such as bathing, dressing, toileting, and feeding the person. They also provide instrumental activities of daily living, such as managing finances, transportation, maintaining the home, communicating with healthcare providers, maintaining the safety of the person, and most importantly, helping to support memory. Overall, these caregivers provide physical and emotional support, ensuring that these individuals with dementia can maintain their dignity and their comfort as their condition progresses. These caregivers face several challenges in their quest to support their person. They face challenges such as lack of awareness and limited access to resources and support services. They tend to experience social isolation and loneliness, and research has shown that there are cultural and language barriers to access and support. They have difficulty navigating our complex healthcare system, as I mentioned earlier. They also feel a sense of responsibility to take care of a person or older adult who helped raise them, especially in the Black community. There's a syndrome, science has named it the Superwoman syndrome. It's seen mostly in Black women, where they feel that they're the only ones who can provide this care. Mom only wants me, or uncle only trusts me, so I have to be the only one, which then makes them carry a higher burden of care. The purpose of my study was to examine the barriers and facilitators of community support service used by Black family caregivers. So barriers, you can tell, is what keeps them from using support services, and facilitator means what guides them or what makes it easier for them to use community support service. We designed a mixed method using the weighted match data from a national representative data set. The NHATS is the National Health, Aging, and Trends Study, which looks at data from the person who has dementia. And then that person, when they're being interviewed, can name up to 5 caregivers. And so the partner data set is the National Study of Caregiving, NHATS and NSOC. We focus primarily on caregivers who identified as non-Hispanic Blacks. We also chose the 2015 version because it had the highest number of people who had dementia classifications. Oops, I'm sorry. The primary outcome that we wanted to examine was caregiver anxiety, And we looked at caregiver anxiety using a tool called the Generalized Anxiety Disorder tool. It is most frequently used to diagnose self-reports of feeling anxiety, I'm sorry. It's used for diagnosing and also assessing the severity of anxiety. And then when we looked at depression, the study used the patient health questionnaire, which is a multiple choice self-report inventory that's used as a screening to diagnose um, the symptoms and get to the core symptoms of depression. Our predictors was community support use, and we specifically looked at support groups, so attending support group or receiving dementia training. Our covariates were caregiver age, gender, education, and family support. So did they have family in the home or around them to support them? Using this data set, we conducted the logistic regression to assess the effect of support service use on depression and anxiety of the caregiver. After the secondary data analysis, we then conducted a focus group. And in the focus group, we looked at Black caregivers specifically. We recruited 6 participants nationally. Mind you, this is right as we were coming out of COVID. So recruitment was very, very difficult. So we were happy to get our 6 participants. We used flyers, social media, and word of mouth. Our inclusion criteria were that the caregivers had to be either current or recent past caregivers. They had to be 55 years and older. They had to identify as Black and English speaking. Our interview focused on determining the facilitators and barriers of support service use. The interviews lasted 60 minutes. It was recorded via Zoom, and we transcribed it using NVivo, which is a qualitative tool for transcription. And then our team completed a thematic analysis, and I will talk about that soon in our results. So now for the secondary data analysis results, here's our sample demographics. And what I want you to get out of this is that most of the participants were female. They were less than 55 years old. They had high school or less education. They also had, most reported having family support. And although the results of our secondary data analysis showed that 93% of our participants had family support, as it related to community support use, so family, people within your network versus community going outside of your network, 3.6% of the caregivers said they attended support groups, and 12.6% of the sample said they actually received dementia training. So we wanted to really dig down and find out if caregivers experienced anxiety and depression. Again, as you can see, our unadjusted mental health prevalence showed that 26.3% experienced anxiety, and 22.9% said that they felt depressed. And then to go further, I'll remind you that we had two main predictors: support group and caregiver training. Our adjusted model found that caregiver training was associated with significantly lower odds of having anxiety. There was no difference in anxiety as it related to using support group or participating in support group. And there was no significant differences in the rates for depression by either using either being trained in dementia or support group attendance. So to summarize our secondary data analysis report, our results found that 93.4% of the sample reported having family support. 3.6% attended support groups. 12.6% had dementia care training. And as far as mental health prevalence, 26.3% experienced anxiety, and 22.9% said that they had depression. And I have to keep making this distinction that people have family members. Like I talked about Johnny Mae, she had 7 adult children, but that did not always result in them supporting the caregiver. So they might be around, but they didn't necessarily roll up their sleeves to offer help all the time. So now let me talk a little bit about our focus group. We had 5 females and 1 male. Again, we recruited nationally. The average age, again, was 55 and over. They were all Black. We recruited and we received participants from the Northeast as well as the Midwest. And these caregivers, oops, provided care to mom. 6 people said they took care of their mother. 2 said they took care of their dad. 3 took care of their uncle. We had 1 that took care of a stepmom. 2 took care of an aunt. There was taking care of a mother-in-law, a husband, and a grandmother. A lot of these caregivers were actually taking care of multiple people at a time, or maybe they took care of someone, that person passed away, and then they were placed back into the caregiver role because they were voluntold by family members because they did so well with the first experience. 1 person was retired and 5 was currently working. The themes that came out of our focus group, when it comes to barriers, things that kept them from being able to access support services, was that they didn't know where to go look for help. They didn't know about the Alzheimer's Association. They didn't know about any of the community help that was in their area. There was the financial constraints. If they found out about it, it was so costly that they could not use it. And then there's the lack of time, especially when it came to support groups. We had several people that said, I can't afford to go to support group. I'm working, and if I go, who's going to watch my person who's living with dementia? And even with the financial constraints, we had a person that talked about having all these multiple family members, but no one willing to share the load of the financial burden of being a caregiver. And then the facilitators was the biggest thing was people said, I heard it through word of mouth. My neighbor had used this service and told me about it. A lot of them used Google to find information and also with past experience. So as they experienced caregiving often, they were able to reach back into their past experiences to connect with services. And here are some of the direct quotes that resulted from our focus groups. We had one person who said, respite care is very expensive. In my state, it is $500 a day. I can't afford that. One person said, I don't have time to attend support groups. Who will care for my loved ones? And then another person said, if you're poor or you're low income, there's more help, but you get better quality help if you have more money. I wasn't able to fit it on here on the screen, but we also had someone that talked about having a big circle, a social circle that was quite vast. But to get someone to come relief and give this person time to practice self-care would mean that this person would have to pay their family member to come stay. He said, I could not get anyone to come and just volunteer to sit with our aunt while I took time away. So to wrap this up and just to bring everything together, we found that Black caregivers receive limited dementia training. They had low use of support groups. Another reason that they didn't seek out support group was the whole stigmatization of mental health and mental illness. And despite having high family support and a vast social network, nearly a quarter report depression and anxiety. Most of it was due to family friction and the battles that they experience within their own family. I'll give you an example of that. Most recently, had a friend who had been taking care of her mom, but then had to give up the role to her sister. And now the sister is looking back and saying to her, you're not here for me as much as I need you to be here. And she's like, but I'm there every day. It's just that I can't take mom into my home. So that kind of friction does add to the anxiety and the depression that goes with caregiving. So you may think that you're carrying the heavier load of being a caregiver and no one's supporting you. Dementia training was associated with lower rates of anxiety, but not depression. We also found that barriers to using community support included limited knowledge, financial and time constraints. There are several implications to this work. We need to continue to study Black caregivers and understand the drivers of poor mental health. We need to continue to have more qualitative work so that we can truly understand what the caregivers are suffering and how we can mitigate some of those, the pain for them. And we need better outreach to Black caregivers regarding availability of community support services and educating providers so that they also understand what's out there and can link the caregivers with the tools that they need. We also need federal level improvement as far as supporting caregivers. And one of the suggestions that I've often made is that we need a voice in Washington for caregivers, have an office of caregivers in the HHS, Health, Human and Health Services, so that the caregivers actually have someone, a place that they can go to get the support that they need. So I want to acknowledge my supporters. I know I talked really fast and didn't use up all the time, but hopefully we can have a discussion and people can ask questions and we can make this an active presentation. Thank you so much. Sorry.
All right, we can open up things for questions. Feel free to unmute yourself and speak if you would like, or if you don't want to, you can type anything into the chat.
Hi, Florence. Great job on your presentation. So my question is regarding just kind of a hypothesis that you may have towards if you were to have used the data from a different time point. I know you had a great rationale for using the 2015 data because the sample size was the largest. But over time, do you think you would have found any similarities or differences if you used data, for example, from a later time point before 2015?
I think before 2015, they really didn't specifically zone in on. Thank you for your question. Great question. They didn't specifically zone in on the dementia classification. It was just broadly chronic illness. So I think if we went further, if we went closer to now, we would still find the same result because people, especially since COVID, it has gotten worse for caregivers and not having the access to tools that they need. Some of the community support services have actually had to close because of COVID, which makes it even more difficult and causes caregivers to be more isolated.
Thank you so much.
Thank you.
All right, I have a question in the chat right here. Hang on one second. Says, thanks for your talk, Florence. Wondering if you have thoughts as to why caregiver training was associated with lower anxiety, but not depression.
I think, thank you for your question. I think it's associated with anxiety because when we train people and teach them what to expect, it prepares them for what they are about to encounter. So when we talk about dementia training, we're talking about the behavioral aspects of it. So as the disease progresses, the person might become more combative. When you're performing personal care like bathing, they might be more combative. So we train people to expect that. But when we don't provide that training, when it happens, they get very anxious, which then it's played onto the person that they're taking care of. So it's just this cycle that they can't break from. But if we inform them ahead of time that you may not see it now because it's early in the diagnosis, but expected down the road. It's almost like if you're driving down the street and they give you a sign that says in about half a mile there's going to be a pothole, so you know to go around it. But I think because the anxiety level is mitigated with the training, it also feeds into the fact that they're not depressed because they now know what to expect. Thank you for that question.
Do you have any programs right now that you're working with that we who are in the community a lot could recommend to people? I know that, at our center, we have, caregiver support groups. A lot of the times they fill up very quickly and people are on wait lists and, just to have that, more resources available to share would be.
Yeah, so currently my work doesn't look to create new support services. I think we have quite enough out there. It's a matter of educating and bringing people to those resources that are there. So, like you mentioned, there's support groups right here in Ann Arbor, IPSI. There's adult day program that gives families a respite. That's my study that I'm doing now, so I'll be happy to come back and talk about that at a later date. There's training through the Alzheimer's Association. They have a wealth of information and support. I want to, if anyone is in the audience who has someone in their lives who's taking care of someone with um, Alzheimer's or dementia, please connect with your Alzheimer's Association. They have a 24-hour line that you can call. You can call them in the middle of the night if you're experiencing some anxiety related to caregiving. There's also area agency on aging. Every state, every county has one, and they provide things like Meals on Wheels. They can guide you to places that can help you with modification to your home. So Alzheimer's Association and your area agency on aging are the two big buckets.
Great, thank you. Any other questions for Florence today?
Any more questions? Left you guys time so we can go back and forth. So I will say that when I started this work, my hypothesis was that Black caregivers did not reach out for help and tended to stay within their own network. And that's essentially what our focus group found, was that people just stay within their own network. And spousal caregivers are really the ones that suffer a lot. I don't like to use that word, but they're the ones that carry a huge burden because they live with that person 24 hours, 7 days a week, and they rarely get a break. On top of taking care of their spouse or mate, they also lose that relationship because now you're not taking care of your mate anymore. It's a person that's totally different. So
Yeah. Have you looked at all into like the availability of using like virtual caregiver support groups versus in person?
yes, so those are popping up everywhere now. The virtual support groups. So that's another area that I can study as I continue to unwind this, is exactly which support services are more attractive, especially to Black caregivers. Once again, there's a stigma about mental health in our community, and trying to break down that stigma. Um, Sometimes what we heard on the focus group is that it's also hard to attend virtual support groups because you still have to be mindful of where your
Yeah.
person is. And it's not always easy to carve out that hour to be able to sit and actually connect on a virtual setting. But at least it's an option. It's better than
Mhm.
nothing.
Florence, can you talk more about just some of the literature on the ways in which Black Americans define or show signs of depression and anxiety, and how that may be different, and whether this questionnaire that they were asked was targeted enough to kind of pick up
Yeah.
those language differences?
Thank you for that question. That's a really good point, is that even in our focus group, we heard that the language that is used by scientists and researchers do not resonate with our community and our population. So instead of saying, let's just start from the beginning, instead of saying, are you a caregiver? asking, do you help anybody? Are you taking care of anybody at home? So they will tell you, I'm not a caregiver, but I'm taking care of my auntie or I'm taking care of my mom. And so talk about, instead of being depressed, do you get time away from caregiving? What do you do to take care of yourself? How do you feel when your person behaves this way? So making it very realistic and not so sterile, and making it sound very science. We Black people have trauma from not all the things that have happened in the history of science. So they don't trust healthcare. They don't trust science. The biggest one that we all hear about is the Tuskegee experiment. So rightly or wrongly, they have trauma from science.
I guess to end on a positive note, like what are some of the ways in which researchers can work together to kind of reduce that trauma in your opinion?
I think that when we conduct research, especially community-based participatory research in Black communities or underserved communities, period, we need to go into the community to be part of the community. So you don't walk in with your survey in hand and just say, answer these questions for me and walk away. You're not going to be successful and your results are going to be skewed. So we say, go in, fellowship, become part of the community, gain trust, bring the community into your work, let them guide your whole process, even down to the question that you're asking. How are you going to analyze this data? The community knows itself and they know better what's good for them than the scientists, even though, sometimes science thinks that they know better. So connecting with the people, getting them to trust you, and being ever present before you even start talking about your science and what you're about to do.
Thank you so much.
Thank you.
Yeah, I think being transparent as to what you're going to be doing with the data as well. Make sure that everybody knows, you know, what their contribution is going to lead to. That's always great. And now with our UMMAP program, we have our feedback sessions that have been very helpful, because now we can give back. We can let people know their neuropsych results, and it's been really, really helpful in the past couple of years since we implemented those.
And also coming back and sharing your results with them.
Yeah.
So here's what we built together. Here are the results. So don't just come in, get your data that you need, go in your lab and run your numbers, and that's it. Bring it back to them. Let's all celebrate our successes. Let's talk about what's the next step. Just really truly getting buy-in, and like you said, Stephanie, being very transparent about where you're going with all of this. And we have to remember that in the center of all the work that we do is our participants, whether it's the person that's living with dementia or their caregiver. They are the expert ultimately in the work that we do.
All right. Anything else for Dr. Johnson? Okay, well, if there isn't anything else, we can end things a little bit early today. Thank you so much, Florence, for giving this talk. It was excellent, and I can't wait to learn more about your future research. And please join us next month, March 17th, for our next Leaders Initiative seminar.
Thank you all so much. Enjoy the sun.
Yeah.